Thanks everybody for joining us at GoLocal Live. It's 12 noon. Joining me in 1 minute is Dr. Michael Fine, former head of the Rhode Island Department of Health. A couple quick programming notes. I want to thank Zach Levesque from North Point, who joined us earlier this morning, talking about what the mortgage situations are, refinancing, getting financing, what's all the dynamics in this economic crisis situation. And then at 11 o'clock, Professor Hillary Levy-Friedman was on. She talked about her new book, really about the legacy of American pageantry. Her mother was a Miss America in 1970, a really interesting story, an interesting piece of work, and a new book. So check that out. That'll be up on GoLocal a little later. And then at 1 o'clock this afternoon, Governor Gina Raimondo will be back with her daily briefing. Let's go to Dr. Fine. Dr. Fine, thanks so much for joining us.
Always good to be here with you, Josh.
Let's go to the numbers. Obviously, there's a little glimmer of two-day hope coming out of New York that the number of deaths have plateaued. Is that an indicator? Does 2 days make a trend, or what do we know from that?
Oh, I think 2 days is a little short to make a trend. You know, I'd want to see 3 days to a week at the end of the day, and I'd want to see, 3 days of plateau and then a couple of days of decline to make sure that we've got a consistent trend. I don't know where they are in New York around isolation and so forth. But I think in New York, knowing it pretty well, and you may or may not know that I spent a little time as a New York City cab driver.
Of course you did.
That it's going to be, that this disease is going to percolate differently in different communities. And so we may make progress in a couple of communities, but, then the disease may arrive a little later in some others, and particularly in places that are densely packed, where lots of people live closely together. We may see fits and starts at the end of the day, progress in one community, but more rapid spread in another. And that shows up, as I've said, 3 to 4 weeks down the line, not great at the moment.
Yeah, and Long Island numbers are spiking. Let's go through the global, national, and local numbers. Can you walk us through those?
Absolutely. 293,000 people have recovered, almost 300,000. 1.364 million people have a diagnosis based on testing. That's an increase of about 70,000 from yesterday. In the nation, 369,000 people now have are tested cases, an increase of about 30,000. 76,000 deaths worldwide, an increase of 6,000 from yesterday. In the U.S., about 11,000 deaths, up about 1,500. Very unfortunately, in Rhode Island, as of yesterday, we had 25 deaths, 922.
27, I think.
Now we're up to 27 deaths, over 1,000 people positive. And 109 people in the hospital with 37 in the ICU.
So this might be around the last few days in which that ICU number stays low. In talking to your peers in the healthcare world, do you see that they've built in enough flexibility to handle 180, 190, 200?
Well, I think we have 180 or 190 or 200. That's what I'm sensing. The challenge is, making sure we don't get double that. It's that group of people, the people who need a ventilator, where the risk of unnecessary death is. Again, we don't yet know the rate of rise. I worry about the differential effects in our communities, that maybe it got more widely into Pawtucket early, and I think the evidence suggests that. But it may take a couple of weeks later to get into Central Falls. I'm a little worried that because of dense population, that we'll see household transmission in densely populated places. So we may see a second bump as the disease has worked its way into these densely populated but somewhat more socially isolated parts of the population.
Providence, Pawtucket, Central Falls have significant populations of those who are undocumented. What's the impact of that? Are those folks going to be, as one, willing to get tested, and B, once developing symptoms, are they going to be as likely to reach out and receive health care in Rhode Island?
I think that's a very vulnerable population. I mean, I think that group of people is often going to work because they feel like they have to. That's what I'm hearing from my colleagues who work with those folks quite directly. They're scared and know they, in general, won't want to get tested and in general won't want to access health care. So, they're the people who will show up late, sick, and in bigger numbers than I think any other population, because it's harder for them to socially isolate, because A, because of the density of population, and B, because many of that community is still working just because they have to in order to survive.
That paints a serious potential problem in those communities that the spread is exacerbated, correct?
Yeah, that's, I'm really worried about those communities. I'm worried about the homeless community because, if we get widespread dissemination of disease in those communities, that can actually swamp the positive effect of the incredible work people have done on social distancing. Social distancing for the population of a whole looks like it's in the main working. But if it doesn't work in these somewhat isolated and densely packed places, then the numbers that can come out of those densely packed places can really be a challenge when you think about, our total capacity.
Since Saturday through tomorrow, Rhode Island will have conducted more tests than they did in the previous 32 or 33 days. It seems like the state's finally got the testing program up and active.
And kudos to the people who got it going.
Is that enough, 2,000 a day? Does that give us enough sampling, enough data to be able to understand what the implications are, model for surges, and know when people can go back to work?
I don't know what that number is. My guess is we need to go between 2,000 and 5,000, and that we need to start testing in a more targeted way. Yes, we need to start testing people with symptoms, everybody with symptoms. That's a really important and valuable component. But we also need to be testing healthcare workers with some regularity, particularly people who work in nursing homes, because there's this great risk of, without meaning to, people may carry the disease asymptomatically into the nursing home. So we've got to test healthcare workers. I think we need to test people who are in isolation before they come out of isolation, so we know they're not asymptomatic carriers. We got a whole bunch of testing opportunities once we have testing that we then need to develop and kind of create an organized approach to.
You make a good point. Those who have self-quarantined because they felt that they had symptoms or had been exposed to somebody who is likely to have coronavirus, those folks right now, when they're done, they're out in the population. Is that a must-test segment of the population?
I've always thought that. I think that was our initial vulnerability when we had a couple of people at St. Ray's, and then we isolated a bunch of people. We didn't test anybody who, as far as I know, we didn't test people who were at the end of their isolation because we didn't quite yet understand about asymptomatic carriage or asymptomatic disease. Those are the people we need to test, in my view, because they're the people who are at risk at spreading the disease. They're the people who are at greatest risk of getting it and then spreading it.
I know you're not a political animal. The national narrative now seems to be, sort of, when did the president know or should have known about the threat of the coronavirus? Isn't that a more universal question? the president aside and the pure politics of it, didn't we just do a god-awful job at the federal level and at the state levels in anticipating that a city in China got shut down with a highly contagious disease of 11 million people? It wasn't shut down the first day of the first case, that would have an opportunity to spread across the country via travel, via contamination.
Well, I think we could have done a better job as a country by far. I'm disappointed in CDC around this for a number of reasons. And, you know, state health departments do mostly what CDC tells them to do. So,
will that happen again? Will states be so deferential to CDC? Will states also, I'll use the word smarten up and start investing in having staffing, apparatus, equipment to be able to take on the next one?
That's the latter interesting and open question. Part of the reason states are so dependent on CDC is that CDC provides 90% of the funding of most state health departments. You know, the entire, you know, state health department.
But you're not restricted to that. We've had this conversation before. Because they give you 90% of your funding, doesn't mean you're barred from adding additional funding. You could you could match that money.
That's exactly the point. If states were funding public health independently, you know, then we would be paying much more attention to the needs of the state instead of to what CDC, what the party line coming out of CDC is today. That's where, you know, the state government kind of dropped the ball in its funding and has for a long time, and that provides that creates a great vulnerability because, you know, we're stuck doing whatever the feds say, and if the feds get it wrong, we just got it wrong.
Right. We're now, if you want to take from Rhode Island's first case on March 1st to today, we're nearing 40 days of a crisis. What have we learned?
Oh, man. Well, I think the first thing we learned was that this is a disease that is spread by people who are asymptomatic as well as people who are symptomatic. We learned many people carry it without symptoms. We learned, I think, to be a little intellectually critical about, you know, what the party line is, and that we really, both state by state and community by community, to a certain extent, stand on our own. We can't wait for what other people do. We have to get started and take control of our own destiny, and do what we can in every single community to prevent the transmission of disease.
After a couple days of stories that GoLocal broke about, especially in Providence, ignoring social distancing restrictions put forth by the governor, the city of Providence has now taken action today and is taking rims off of backboards, picking up all athletic equipment. Is that another lesson that we just need to learn? This is going to happen again. We know it's going to happen again. Do we need a much better, deeper playbook?
I think we need a better, deeper playbook. I think mayors need to get involved in a different way. One of the Rhode Island vulnerabilities, perhaps, is that we have only a State Department of Health. We don't understand that in most states there are also local departments of health, and they have responsibility and advocacy. They push mayors and city councils in ways that the State Department of Health may not. So maybe we'll get cities start to think about developing their own offices or departments of health who can better drive the public health process in collaboration with the State Department of Health and with the CDC. This is a collaborative enterprise.
New York Times, we cite it today, has a column piece from a researcher who sort of outlines the 4 triggers to being able to determine that we can start to regain some normalcy. I'm not sure if you saw it or didn't. Yeah, so that seems a positive in which there's at least the beginning of a discussion about what this what those triggers are. But in some of them, because of the lack of testing, not only here early, but also in other states, how do you even determine that? If you're talking about a virus that 100 or 200 million Americans are going to get, we're not close to having any understanding of where we are within that superstructure.
Well, I think in terms of that specifically, testing is going to get better and get better fast. And when I talk to my colleagues, I explain that from my perspective, the testing process is going to flip around every 3 days to 2 weeks. I think there are things that what they're doing up at Twin Rivers is going to be useful. If we can expand that, I can imagine a world in which we get little test strips that we can give out to almost everybody, and people can start testing themselves. And my guess is we're a month or two off from that, but when we get to that, that's part of how we're going to think about getting back to normal.
The test process at Twin Rivers quick. The line is long. Are we missing a revenue opportunity? Not having slot machines every car length away, so that those waiting to take the test would have the opportunity to make a bet or two and help the Rhode Island tax revenue come in.
Yeah, I don't think I want to go there. But I would like to know more about what's called the sensitivity and specificity of the testing that's being done at Twin Rivers and compare it to the other testing. These are technical.
Yeah, so we reached out to CVS yesterday after our conversation to Mike DeAngelis, who is spectacularly responsive. They are using that new Abbott machine. We do have questions into Abbott's corporate communications, and as soon as we get that, we'll share that with everybody.
Great.
Anything else folks should know today?
I think continuing to work hard on the social distancing stuff, thinking about what you do should you get sick in your house, and then preparing yourself emotionally for what's going to be a rough couple of weeks. I think, in Rhode Island, we're not going to have as tough a time this week, but in the next 2 weeks, it's going to come. This is the time to reach out to family and friends and to find a way to be together and stay together, because it's together that's going to get us through this.
Dr. Michael Fine, as always, thank you very much. Always a bastion of knowledge. And the response from readers and viewers has been just spectacular. For everybody else, we'll be back at 1 o'clock with Governor Gina Raimondo with the latest state update. Thanks, everybody, for tuning in. Stay safe. Looking forward to see you back this afternoon.